Yeah, good evening, everyone. Thank you, Dr. Roberts. Yeah, I've been here for 2.5 years now, and I'll be talking about PE, pulmonary embolism. From what I've known, that mostly we've been transferring out the PE patients, especially if it's intermediate risk, which is considered as submassive PE, or a high risk PE, which is also known as massive PE. So the difference is in submassive PE, you have evidence of right heart strain, and in the massive PE, patient is hemodynamically unstable, it's coding, or they have signs of hypoperfusion. So um, since only last year I came to know that we've been transferring such patients out. So I said, no, I do specialize in endovascular treatment for venous thromboembolism, including pulmonary embolism. So we started doing catheter-directed thrombolysis for PE last year, and only this year we started doing a new, most effective and very, very safe treatment called mechanical thrombectomy, and it's done percutaneously. So that's so what we do in this procedure is that we put a big bore catheter through the right common femoral vein all the way into the pulmonary artery, and apply 60 cc syringe at the other end of the catheter and basically just suck out the clots. And the good thing about this procedure is that we can filter the clot out and re-inject the entire 60 cc's of the blood back into the patient. So the blood loss is only less than 50 cc's for the whole case. The reason why I started doing this procedure is because, yes, catheter-directed thrombolysis was effective, but it still involves giving IV TPA. And so there is still a risk of bleeding in giving lytics. And anybody more than 65 years of age, we cannot use lytics because theoretically there is still a risk of intracranial hemorrhage. So out of the 10 cases that I was asked to perform this procedure last year, I had to turn 3 or 4 down. But I did catheter-directed thrombolysis for the other ones. But now that with this procedure, the risk of bleeding is almost next to very, very less than 0.5%. Now we can offer this treatment to even those patients more than 65 years of age. And it's been well studied. This slide shows that this is for the intermediate risk PE. The good thing about this procedure is that you see immediate hemodynamic improvement on the table. The patient start feeling better on the table itself. You can see that after we suck out all the blood, the PA pressure on an average drops by 7.4 millimeter of mercury. The cardiac index increases by 80%. Even the heart rate start coming down. And if you see here, the median ICU stay is 0 days. So after this procedure, the patient does not need to go to ICU. They can directly go to a step down, and most patients can be discharged after 1.5 days. So that's the biggest advantage of this procedure. For catheter-directed thrombolysis, we still had to admit those patients overnight in the ICU, give TPA, but this procedure practically eliminates the ICU stay. And the other important advantage is that once we remove all the blood clot, the incidence of chronic PE is also very less with this particular procedure. So if you can go to the next slide, please. Yeah, so this slide basically summarizes the difference between the catheter-directed thrombolysis versus flow retriever system, which is a system that we use for mechanical thrombectomy. And you can clearly see that even with the traditional therapy with anticoagulation and lytics, the mortality rate is close to 10 to 16%. But with this procedure, the mortality is only 1.3%. And look at the long-term outcomes. So for the traditional arm, almost 24% of the patient still have poor long-term outcomes, which includes readmission and also a chronic PE in a very long term. But here, even that is significantly decreased by this particular procedure. And most recently, just a month ago, they studied percutaneous mechanical thrombectomy in a high-risk patient. And this was this was excellent trial, and it showed almost 90% reduction in mortality. So they had to prematurely stop this trial because of overwhelming benefit. And just a little word about the high-risk PE. So the only treatment that we had until now was to give IV TPA because patient is coding, and the only treatment is just give IV TPA. But even with that treatment, 40% of the patients don't end up getting IV TPA. Why? Because they have contraindications. They had recent surgery. They've had other bleeding events. So they don't end up getting IV TPA. And even if they get it, not all the patients survive. Why? Because IV TPA itself carries high risk of bleeding. So people were dying even with bleeding. So overall mortality was close to 25%. Now with this percutaneous mechanical thrombectomy, mortality is brought down to 1.9%. So it's like 90% reduction in mortality. So this is pretty significant, and that caught my eye. And even with STEMI, these days we have mortality of 2%, but PE carries mortality of 25%. So this procedure, in a way, it's very, very effective. Now, this is our first case that we did here in February of this year. It was for a submassive PE. And you can see here, after we removed all the blood clot, which was mainly from the right lung, patient's PA pressure dropped from almost like 65 to 43 systolic. And this is our cath lab team. And that's the next case. These are the two cases that I did for massive PE. Look at the amount of the clot we removed from both the lungs. And again, you can see that on the table itself, the PA pressure gets normalized on the table. And patient's oxygen saturation also gets better. Next slide. And this is, we do it under fluoroscopy, and this is how it looks. This is a big, large bore catheter. So this is a case of a massive PE. You see, I'm injecting a dye, and you can see there is no contrast going to the entire lung. So initially, I removed the clot from the right lower lobe, got a perfusion there, and then I redirected the catheter to the upper lobe, and now we can see that there is a perfusion to the right upper lung as well. And the same patient, the next slide, please, also had tremendous clot in the left lower lobe of the lung. And again, after removing the clot, the blood flow is very good. So I've already done 6 cases. In fact, a matter of fact, last Saturday also I did one case for a massive PE. It's very effective, very, very safe, does not require ICU admission, does not require lytics. So practically there is no contraindication in terms of any recent bleeding or the age of the patient. In fact, all these trials enroll the patients up to 80 years of age. And my second patient in UNC Southeastern was 84-year-old female, and she did fine. So that's a treatment we've been offering here. And ideally, obviously, we would like to have more operators so that we can create a so-called PERT team, which is PE Rapid Response Team, and that's the next goal. I've already have one of our interventional radiologists, Dr. Jeff Zapava, who's shown interest, and he said that he'll be happy to learn and share some calls with me. So that's where we are. And I'm open for questions.
Thank you, Dr. Patel. I definitely want to open up to the group and try to understand. Maybe we heard some of the inclusion criteria, which is broad, and maybe just touch on some cases of exclusion. An 84-year-old female, I'm guessing it's pretty broad inclusion criteria there. So from the community standpoint, is making sure they understand the target population for the patients and what they can expect post-operatively. It sounds like there's a lot of decreased complications right from the beginning, from the table. So just have people have opportunity to talk about that and what they can expect in the long term for these patients as they come back to their office.
Yeah, so all the patients get started on the newer oral anticoagulants. And as I said, most patients get discharged day after tomorrow. And practically, it's just like seeing any PE patients getting discharged from the hospital on the newer oral anticoagulants. Um, uh, they usually follow up with me as well. So there is no special follow up they need to do. I mean, as long as they follow up with me, obviously what I will be doing is to make sure what's the cause for PE, like inheritable causes versus a provoked PE, and accordingly decide the duration of anticoagulation. So that's one thing that we need to decide on a follow up. So either hematologist can do it, or even I take that upon me, and I do all the hypercoagulable workup, and accordingly I decide whether this patient should be remaining on the long-term anticoagulation or not. But apart from that, there's no special precautions or something that you need to check out for. I mean,
So we do have one question just
sure.
in the chat from Dr. Lowry. She was just asking if you currently are the only one in the region doing this procedure.
Yes, currently I'm the only one doing it. But we on the weekend we share call. One of the weekend is done by the UNC cardiologists who help us with the STEMI call, and they also do this procedure. So if at all, so at least 2 weekends we are covered. If any patient comes with P over at least 2 weekends a month, we can get this procedure done. In the weekdays, what my plan is, see, submassive PE patients, they can wait up till 12 hours for me to get them to that, to do this procedure. So if the patient comes over in the evening or in the night, I can always cater to that patient the next day in the morning. So I'm in the cath lab for at least on an average 2 days a week. But even if I'm not in the cath lab, I can still, my plan is to accommodate those patients, and I can come to the cath lab, get this procedure done, and then continue with my clinic. So the intention is until we have 3 full providers performing this procedure, I'll try to do as many cases as I can. And so far, if I have to give an idea, in last 2 months, out of 10 PE cases, maybe 2 had to be transferred out because I was not there and nobody else could do this procedure.
Right. I'll try to get with you, Dr. Patel, after the call. Do you have the actual journal article that this came from, where they had to stop the trial because of the overwhelming benefits of the treatment arm?
Sure. So the snapshot has been in this presentation itself. That's the FLAME trial. It was presented a month ago in ACC.
Okay.
And the second, and the trial for the intermediate risk PE was the FLASH trial that also is included in this particular presentation. If you go one slide back, one more. Yeah, that's the FLASH trial.
This one. Yes.
Yeah.
Okay. I'll try to pull up those articles and have those available. I'm sorry, did I spoke
Sure.
over someone?
No, that's.
Dr. McLeod, do you have any questions from a outpatient
A
perspective?
comment and a thank you. One of your interventions was one of my 83-year-old patients who did extraordinarily well. I saw her in follow-up, and she was thankful. I was thankful, and wonderful job. Just a fascinating procedure, and I'm thrilled that we have it in this facility.
Oh, thank you. Yeah. So she must be the one who was 83 or 84-year-old female. Yes. Yeah.
Yeah, that's correct.
Yeah.
Delightful lady, delightful family.
Yeah.
And had an acute PE, and you intervened almost instantly, and she did great.
Yeah.
Dr. Noor, I wanted to give you, as a new participant, opportunity to speak or ask any questions as well if you have any. It's certainly not required, but want to make sure everyone's voices and comments are heard.
Now, I have 3 physical therapists who are my friends, and they usually cater to the to patients in Lumberton. And all my PE patients ended up was seen by them. So they also gave me a follow up that they're doing okay and so forth. So
All right, well, outstanding. Thank you, Dr. Patel, for taking out time. I certainly enjoyed it. I think it's good information, and try to keep the good work going there at the hospital. Joe, do you have anything specific to add?
No, I agree. This was very exciting news, and I think Dr. Patel, I may be calling on you to see if you would be willing to speak to the board about this procedure as well.
sure, I'm happy to do so, Dr. Roberts. Sure.
All right. Well, thank you so much.
Thank you. Thank you, everyone.